Right. Good evening, everyone, and welcome to another one of our HEMONC sessions, which I'm sure are probably one of the best sessions, online sessions, which all of us look forward to. The faculty as well as the participants look forward. For today, we have ALL, which is literally a bread and butter for a person who does HEMONC. And I'll hand over to Dr. Vandana to start the session of the evening. Over to you, Dr. Vandana.
Thank you, ma'am. Good evening, everybody. It's a pleasure to be back here again on the online training program for pediatric hematology oncology trainees and faculty across the country. So today our topic is relapsed acute lymphoblastic leukemia. So we all know that it's the fourth most common malignancy that we all come across. Sometimes more common than many of the solid tumors that we encounter. So it's really important for us to know what to do with relapsed ALL. And as we get better and better at treating, we are going to see more and more relapses. So to deliberate on the issues of relapsed ALL across the world and what it means for us in this country, we have two experts today. And it's my pleasure to welcome Dr. Dharini, faculty at Sri Ramchandra Institute of Medical Education and Research at Chennai, and their fellow, Dr. Hasita, for the first part of the talk. So they will present some cases and go through the approach to diagnosis. And further on, we will have Dr. Shekhar Krishnan to talk to us about management and where we are in 2023 on the management of relapsed ALL. Dr. Dharini, over to you. Thank you.
Thank you so much, Dr. Vandana. At the outset, we would like to thank the team, Amita ma'am, Dr. Vandana, Dr. Preetham, for giving us this opportunity. We hope we do justice to the session. Hasita, can you start sharing the session screen?
Yes, ma'am.
Yeah, thank you. So we have kept our first 30 minutes in such a way that I give the theoretical or to know aspects of the relapsed refractory pediatric ALL. And then Dr. Hasita would present 5 cases which have been managed, who have been managed at our institute for relapsed ALL. So again, thank you for the opportunity. So with this, we'll go to the overview. We all know that the pediatric BALL is the most common malignancy. The next slide, Hasita. So BALL is the most common malignancy. We all know that. ALL being most common, we also come across relapsed ALLs as well more commonly, more than even some of the solid tumors. So outcomes across the nation, we know that it averages around 75 to 80% with a lot of scientific advances. Still, we carry a 10 to 15% risk of relapse when we treat these children. Of course, with advances in HSCT and immunotherapy, we still have improved survival. But yeah, we are going to discuss about what we are doing right now. So the next slide. So these are some of the factors which are present at primary diagnosis, which portends an increased risk of relapse. So we all know that these are the characteristics which mark a high-risk disease. So any infantile ALL or ALL more than 10 years, WBC more than 50,000 at diagnosis, a male gender, CNS positivity, poor response to therapy, be it a poor prednisolone response or an MRD response, or a T-cell biology, or the high-risk cytogenetics. We all know these are the high-risk features. Of course, the high-risk features translate into a higher risk of, factors which portend a high risk of relapse. So the next slide. So when it comes to a child with a relapsed so we often get confused. Of course, it's an anxious moment for the doctor, for the patient. So we have to go systematically. So these are the 2 basic points which we need to understand and remember before we put them into any risk stratification or start managing. So this is where we start. So what is the site of the relapse and what is the time of the relapse? So these are the two main factors which will help us to risk stratify them. So the next slide. So coming to basic concepts of relapse. So we all know the basic diagnosis of leukemia, how to mean more than 25% blast. So we again have standard diagnosis for when to call it a relapse. So the sites, we all know that bone marrow, it is the primary site. And there are sanctuary sites like CNS and testis. There are some other extramedullary sites apart from the CNS testis, which are well known, which can occur very rarely. So the classical diagnosis is more than 25% blast in the bone marrow will qualify for a bone marrow relapse. It can be either an isolated or a combined relapse. So when we have to call it a concurrent or combined relapse, we need to remember that even presence of more than 5% blast is enough to call it as a bone marrow involvement. So only for isolated, we have need a more than 25% blast criteria. So again, if it is isolated CNS, the standard diagnosis more than 5 cells in a classic CSF preparation with without major RBCs, and there should not be disease anywhere else. An isolated testicular, again, leukemic infiltration demonstrated by biopsy. It is histologically diagnosed, and there should not be blast elsewhere, and bone marrow should have less than 5% blast. So the next slide, please. So these, to summarize, this is isolated marrow. If it is concurrent marrow, a presence of 5% blast is enough, plus other side. Isolated extramedullary can be a CNS testis or other sites being the bone, orbit, mediastinum. All these are very rare situations where again the marrow should have less than 5% blast. So next slide. So this is how they are going to present to us. So usually they may range from an asymptomatic presentation. Children may be very well, they just come for a routine follow-up. We often find the hepatosplenomegaly, or we find obvious blast in the peripheral smear when they come for regular follow-up. Or they can have a systemic signs which can be fever, pallor, bleeds, which all can happen with upfront ALL. Or they can have CNS signs and painless testicular enlargement in the boys. So obviously when there is one testis involved, we always have to look at the other testis, both clinically and histological aspects as well. The next slide. So this is the incidence of relapse, which is quoted by various studies as shown here. So we have seen, as we see here, the isolated bone marrow is the most common site of relapse. So the bone marrow is the most common. So again, isolated bone marrow is the more common site, followed by combined bone marrow and an extramedullary site, and followed by, isolated bone marrow, followed by isolated extramedullary and combined in a equal proportion. So as quoted by various studies. And isolated testis is reported to be very rare, and isolated extramedullary without involvement of other sites, as we discussed, is very, very rare. In only very few reports we have found. The next slide. So that is with the site of relapse. When it comes to the time of relapse, so this is how in general we classify. When it is from within 18 months from the time of diagnosis, we call it as very early relapse. If it is 18 months of diagnosis to 6 months of treatment completion, we usually call it as early, or more than 6 months is treatment completion is late relapse. So the next slide. So this is for us to remember easily. So there again, based on the upfront protocols that is being used, so COG defines it in a way, BFM has a definition, more of, all of them usually are almost similar, except for a slight difference. COG puts it as within 6 months from diagnosis and more than 6 months from diagnosis as early and late. And among the early, they call it as very early, which is less than 18 months. And again, the 18 to 36 months criteria. So only this 30 to 36 months is dealt different between the COG and BFM, where the COG calls it early and the BFM protocol calls it late. And this is a very small window. The next slide. So again, we have talked about the time of relapse. So we know what are all the sites, we know what are all the, when it can relapse. So just to brush up a few risk factors, we have already discussed this in the first slide. And there are few pointers like the T-ALL phenotype, hyperleukocytosis, high-risk cytogenetics like MLL and BCR-ABL, initial CNS positivity. All these are specific risk factors for a impending CNS relapse in future. The next slide. So the disease biology has been studied in very much detail. So we have heard about this in lots of conferences and scientific meetings. So the two concepts are that there is a clone which has been resistant and has been present from the beginning, or some clone which is evolving later. So this correlates with an early versus late relapse. So this is just to put it in a nutshell, but there are lots and lots of studies just going on. So studying the biology of these disease at diagnosis and when they are in remission in MRD negative states and at relapse, people have found a lot of people have tried to understand the of the disease. The lesion-specific backtracking studies reveal that in most cases, the relapse clone existed as a minor subclone within the diagnostic sample prior to the initiation of therapy, suggesting that the relapse clone was selected before the treatment was started. So they have been silent and they have come up later after the treatment intensification is lessened or when the treatment is stopped. In only a minority, that is 6% of cases, did the relapse clone represent the emergence of a completely distinct, genetically distinct, unrelated second leukemia. So most of it is usually the same disease that we have seen, either with a resistant clone which is coming up or some clone which has come up, which has developed resistance during the treatment. So the relapses may be the result of selection of a relatively resistant clone which is present already at diagnosis. Second slide. So again, the same thing is reiterated here. So with the references, so the study says that the intrinsic drug resistant, the malignant cells responsible for relapse presenting at diagnosis and mutating to resistant phenotype, late relapse representing de novo development of a second leukemia through a common pre-malignant clone. All these have been the biological explanations given for the disease having an early versus late relapse. Next slide. So I'm not going into the biology details, but the nutshell is there is a clone which is coming up later, or there is some mutation acquired later during the treatment. And very rarely it is a different clone completely. So the risk stratification, so with whatever we discussed, that site of relapse and time of relapse, we usually come into a risk stratification, which is important before we decide on the treatment. Again, the various groups, the OG, BFM, and UK groups have defined the low, intermediate, high risk groups based on this time and the site of involvement. And some groups have also included the MRD response at the time of reinduction. The next slide. So again, this is BFM and UKLLR3 study and the BFM study, international BFM study group risk criteria, which says a very early, late, and the isolated combined and isolated marrow, isolated extramedullary, and combined. So again, based on these, we stratify them into standard, intermediate, and high risk. So next slide. So I will not go into this. So we know Dr. Shekhar will be discussing in detail. So there are reinduction regimens, chemotherapy protocols for the reinduction regimens and the ongoing chemotherapy. Transplant is definitely has got a role. And we have the newer options coming up. And there are many other novel agents for TALL, BLL. And so it is all coming up. So we'll discuss that in the management. The next slide. So again, these are the management strategies, the treatment algorithm for first marrow relapse, isolated relapse. So how do we go about? So usually we start with the 4-drug reinduction. That's the whole idea. And then we assess the MRD response at the end of 4-drug reinduction. And then based on the response and the preliminary characteristics, we go on to the continuation therapy. The next slide. Next slide. So again, there are very standard criteria, definitions to even define the response evaluation after relapse. So the M1, M2, M3, CNS, testes, and so we have all the thing. And even for to define the treatment failure and refractory patients, we have the standard definitions. So the next slide. So I'll just touch into few factors which we've been already discussed. I'll just try to highlight few points which would tell us about the prognostication at the time of relapse. So first thing is the length of first remission. We have already discussed this. The disease that relapses very late has got a better prognosis compared to the disease which relapses very, very early. So which is what is shown here. So the usually this is the point which is showing 74% relapsing within the first 3 years and 4% after 6 years. This is the timing of relapse. And as we see here, the CR rates for the very early and late relapses. So the late relapse with 93% and 83% for early, this is the overall survival. And whereas 5 to 18% of EFS and 19 to 57 for late relapses. So this clearly says that whoever has a late relapse has a better prognosis. And it is generally found that the CNS relapses usually tend to occur earlier, whereas the late relapses are usually, the testicular relapses usually are late. The next slide. And based on the site, we know that 60 to 80% of the relapses involve the bone marrow. The bone marrow relapse has worse prognosis if it is involved. And when it is isolated, definitely it is worse than when we have a combined relapse. And the isolated extramedullary has got a better prognosis. So this is the survival, 3 to 6 year survival, 20% for the isolated marrow relapse, 50 to 80% for isolated extramedullary relapse, with something in between for the combined relapses. So this clearly says that isolated marrow has got the worst prognosis. So next slide. So this is said that, so why the isolated marrow has got the worst prognosis, it has been hypothesized that the combined bone marrow relapses originate from the involved extramedullary compartment in which the leukemic cells could survive the frontline chemotherapy. So basically when they have an extramedullary disease, it is probably because they have hidden in the sanctuary sites and then they have escaped. So, so they are expected to respond better to the previous treatment, which has been already given. So the one slide previous, sorry. So the MRD response at relapse has again a very important prognostic thing. So those who have MRD negative late relapses again have the best prognosis in the whole lot, whereas MRD positive early relapses have the worst outcomes. So we can put it accordingly. So next slide. So TALL relapses tend to occur earlier rather than having late. Late relapses usually have the BALL phenotype, and WBC at relapse less than 50,000 again, as in upfront disease, it also has got a prognostic marker. And we know that the unfavorable cytogenetic markers like the PH, positive ALL, MLL gene rearrangement, all these have been associated with poor risk even in the relapsed setting, as in the upfront setting. The next slide. So the genetic alterations at relapse, so though they are not routinely used in the risk assignment, but they give us some clue towards how do we treat the Philadelphia chromosome. Of course, we need to decide on the TKI, change the TKI based on the imatinib resistance mutation analysis. If someone is on imatinib and then on relapsing, we do the imatinib resistance mutation analysis and then try to change to the second line TKI. And JAK2 fusion, if it is present, the addition of ruxolitinib might help. TP53 mutations, if it is acquired at the time of relapse, the prognosis is very bad. So even if they have a negative MRD, so we need to consider treatment in terms of transplant. So again, even in late relapse with high risk somatic genetic alteration, these will help us towards guiding the therapy. So next slide. So this is the overall outcomes based on the various groups. I just to point out to say that we have been in the range of 50 to 70%, as discussed for isolated extramedullary, the most late isolated extramedullary, and the worst for the early marrow relapses. So next slide. So finally, a word about relapse after the transplant. So it has got very, very dismal prognosis. And again, timing of relapse even after transplant has some meaning. So those who have relapsed more than 12 months, still people try the second reinduction and second transplant. But anyone relapsing in less than 1 year post-transplant, the prognosis is almost dismal. Of course, here is we have where we discuss the novel therapies, which we'll discuss in the management. So next slide. Thank you. So with this, I would request Dr. Hasita to present few cases. Whatever we have discussed here, we have stratified our patient, and you would just give an overview of how we managed, so that we can discuss at the end if there are any refinements. Thank you.
Are my slides visible, ma'am?
Yes, please go ahead.
Good evening, everyone. I'm Hasita, PHO Fellow from Srihar, Chennai. Firstly, I thank you all for this opportunity. And now I would like to present few case scenarios which were managed at our center, emphasizing on risk stratification and management. So the first case is about a 12-year-old boy. When he was initially diagnosed, he presented to us with complaints of fever, easy fatigability, and bone pains for 15 days. Regarding the risk stratification, his counts were more than 58,000, with peripheral smear showing 80% blasts and 78% blasts in bone marrow. Flow cytometry was confirmative of B-cell ALL. Chest X-ray showed no mediastinal widening. We did this cytogenetic panel, and he did not have any high-risk cytogenetics, with karyotyping being normal. He did not have CNS disease or testicular involvement, and his day 8 prednisolone response was good. So he was started on induction chemotherapy with 4 drugs in June 2019. His end of induction assessment with MRD was more than 0.01%. So he was re-stratified as high risk, and he received augmented BFM consolidation. He attained MRD negativity at the end of consolidation, and followed by which he received high-dose methotrexate, interim maintenance, delayed intensification, and maintenance chemotherapy. He's completed his treatment in June 2022. 1 month from stopping maintenance chemotherapy, at the age of 15 years, he's presented to us with complaints of headache for 10 days and fever for 2 days. On examination, there was no testicular involvement, and when we evaluated, his CBC was normal. So we proceeded with bone marrow study and CSF study. Bone marrow showed 6% blast with positive CSF cytology and 1,000 cells, 1,000 CSF cell count. With this background, we repeated cytogenetics, which showed no high-risk cytogenetics, and karyotyping was normal. And his bone marrow blasts were taken significant. As he had early combined B-cell ALL relapse with medullary and CNS involvement, he was re-stratified as intermediate risk as per UK-ALL R3 protocol. He received reinduction with 4 drugs, and end of reinduction MRD was less than 0.01%. He also simultaneously he was started on adequate antiviral and antifungal prophylaxis. He completed his consolidation and intensification chemotherapy as per UKLL protocol, and he's completed it in November 2022. As he had early combined relapse, we have counseled him for transplant. As he had no sibling or parents match, we have proceeded with 10/10 mud transplant. He's received cranial boost and total body irradiation, followed by conditioning chemotherapy. Methotrexate and tacrolimus were given for GVHD prophylaxis. He attained WBC engraftment on day plus 17, and his donor chimerism on day plus 19 and 45 was 100%. Day plus 45 MRD is less than 0.01%. Currently, he is day plus 50 and he is doing currently well. Coming to the second case, this is a 3-year-old boy at the time of diagnosis, presented with fever and pancytopenia. Regarding the risk stratification, his counts were 2,840 with peripheral smear showing 20% blasts and 78% blasts in bone marrow. Flow cytometry was confirmative of B-cell ALL. Chest X-ray showed no mediastinal mass. And cytogenetic panel showed no high-risk cytogenetics. Bone marrow karyotyping was normal. He had no CNS disease or testicular involvement, and he had good peripheral blast clearance by day 6. He received induction chemotherapy with three drugs, which was started in October 2014. He attained MRD negativity at the end of induction. He received standard consolidation, interim maintenance, delayed intensification, and maintenance chemotherapy, which was completed in October 2017. And his end of treatment assessment was normal. So 2 years from completion of treatment, at the age of 12 years, he presented to us with painless hard mass in left testis. And on evaluation, his CBC was normal. He did not have any bulky disease. Peripheral smear and bone marrow showed no blast. His karyotyping was normal, and there was no evidence of CNS disease. In view of late isolated extramedullary relapse, he was re-stratified as standard risk as per UKALL R3 protocol. And he received reinduction, and MRD at the reinduction was less than 0.01%, followed by consolidation. He received radiotherapy to testis with 12 grays at the end of intensification and maintenance, and simultaneously subsequently received the maintenance therapy as per UKLL protocol. He completed maintenance chemotherapy in December 2022. Currently, he is asymptomatic and is doing well. Case 3 is about a 14-year-old female presented to us with complaints of pallor and gum bleeds. On examination, she was noted to have hepatosplenomegaly. There was no bulky disease, and there was no evidence of bulky disease. I mean, the chest X-ray was normal, and CBC showed only 500 cells. Peripheral smear showed 89% blast, and bone marrow aspiration showed 100% blast. Flow cytometry showed CD10 negative. So we were suspecting MLL rearrangement, which was confirmed in the cytogenetics panel. Karyotyping was normal with no evidence of CNS disease and good prednisolone response. She received induction therapy with 4 drugs, which was started in June 2018. She achieved MRD negativity at the end of induction, received augmented BFM consolidation, high-dose methotrexate, interim maintenance, delayed intensification, and maintenance chemotherapy from March 2018 to September 2018. In view of MLL rearrangement, the risk of relapse and possible need for HSCT was also counseled. So when the child was on maintenance phase, she was noted to have headache, which was not relieved on analgesics. So we have evaluated, and CBC showed hyperleukocytosis with 80% blast and thrombocytopenia. Peripheral blood flow was suggestive of B-cell ALL. There was no evidence of CNS disease, and she had MLL rearrangement again. In view of very early isolated marrow relapse, she was restratified as high risk. And parents were counseled regarding the diagnosis, dismal prognosis, chemotherapy options followed by HSCT, but they have opted for palliation due to social reasons. So the case 4, this was a 7-year-old boy. When he presented to us with complaints of high-grade fever for 7 days, His CBC was normal with peripheral smear showing 39% blast and the bone marrow aspirate showing 80% blast. Chest X-ray was normal. Flow cytometry was suggestive of T-cell ALL. Karyotyping was normal. He had no evidence of CNS disease or testicular involvement, and he had good prednisolone response by day 8. He was started on chemotherapy with 4-drug induction in June 2018, and he attained MRD negativity. He did not achieve MRD negativity. It was 4.5%, stratified as high risk. So he received augmented BFM consolidation, and the end of consolidation assessment was also positive with 0.3%. So he is a refractory T-cell ALL. So he was counseled regarding FLAG, IDA, salvage chemotherapy followed by HSCT, but parents opted for continuation of delayed intensification. So when on delayed intensification, he had continuous high-grade fever spikes with generalized lymphadenopathy and hepatosplenomegaly. And evaluation done then showed 26% blasts on peripheral smear and 84% blasts on bone marrow aspirate. Flow cytometry was suggestive of TALL. Bone marrow karyotyping was normal, and CNS disease was present with no testicular involvement. He was restratified as high risk, and the chemotherapy options and the HSCT options were explained to the parents, but they have opted for palliation due to social reasons again. So this is slightly a different scenario about infant ALL. This child presented to us at 6 months, a boy child with complaints of fever and massive splenomegaly. He had bicytopenia with hyperleukocytosis and peripheral smear showing 94% blasts. He did not have any bulky disease, and his chest X-ray was normal. His karyotyping was also normal with no evidence of CNS disease. Usually we expect MLL rearrangement, which was negative in this case, but he had good response by day 8, and his end of induction MRD was negative. He was actually started on interfant protocol, and in view of infant ALL with hyperleukocytosis, we counseled the parents regarding HSCT, but he had no sibling and parents were only haplomatch, and there was no matched unrelated donor available. So parents opted for chemotherapy. So he was being continued on infant ALL interfant protocol. So while he was due for maintenance, he relapsed. So he was reinduced with 4 drugs with mitoxantrone, and the end of induction MRD was 0.15%. So in view of relapsed refractory disease status, we have given him blinatumomab, 1 cycle blinatumomab, and he attained MRD negativity at the end of 1 cycle of blinatumomab. And we finally proceeded with haplo HSCT with father as donor. And the conditioning chemo given was fludarabine, busulfan, ATG with post-transplant cyclophosphamide. But he finally succumbed to sepsis with multi-organ dysfunction. Thank you.
Thanks, Ashita and Dr. Gardni, for the nice overview of identification of relapsed ALL in children. So I think we now move to the next part of the session, which will be on the management aspects of relapsed ALL. And as we know that salvage protocols are often pretty intensive and toxic. And now with the advent of the immunotherapy, the therapeutic armamentarium of relapsed ALL is expanding. To understand more clearly on the management aspects, may I request Dr. Shekhar Krishnan to start his presentation. I don't think he needs any introduction. He's a senior consultant of pediatric hematology oncology at Tata Medical Center. Over to you.
So thank you everyone very much. And first of all, I want to express my gratitude to Dr. Vandana and to Dr. Preetham for the opportunity to talk to all of you. Also to my colleague and respected senior, Dr. Amita Trehan. And also I want to communicate my gratitude to all of you for spending time to listen. I am at a place where the internet connectivity is a bit tenuous. So what I shall do, with your permission, is to switch off the video, share my screen, and talk about the and do the talk. Thank you. So I trust all of you can see my screen. I shall move to screen mode. So what I shall do is I'm very sensitive to the fact that we have time sensitive. So I may skip some slides because they have been already dealt with before. As Dr. Vandana mentioned, it is the fourth most common, relapsed ALL is probably the third or fourth most common pediatric cancer. But also it is probably the second or third most common cause of cancer-related death. And for that reason, it's an important disease for us to understand. Now, the next of the talk that I've fashioned here is designed for clinicians who work at the bedside, jobbing clinicians. So it's most focused on trying to use information that is available in published literature and our own experience, be able to manage patients. And I've divided it into 4 groups. First, where we suspect, evaluate, and confirm. This has been dealt with very clearly by Dr. Dharani. I may touch on 2 points, and then I will move quickly to the subsequent phases. Alleviate, communicate, support is when we talk to families about the diagnosis. I shall reserve this for the last bit of the talk. Stratify, review, plan is where we decide on how to manage, and manage and monitor is where we actually implement the decisions. So suspect, evaluate, confirm. This has been dealt with before by Dr. Dharani, but I shall just mention a point that one of the unusual presentations of relapsed ALL is that it is multifocal. So if you, Professor Vaskar Saha, who's my mentor and a consultant in my department, talks often about, asks us to visualize when we have a snow-carpeted field, and when the snow then thaws, what happens is that there are pockets of snow still remaining, and that's what seems to happen in ALL as well. So if you look at this, this is actually a real-world report. This patient had had testicular enlargement suggesting testicular relapse. A bone marrow study was done. The aspirate, which is highlighted here, shows a normal cellular marrow with all elements represented, and a blast count, which is less than 5%, suggesting that the marrow is actually in remission. And that was also confirmed by flow cytometry analysis of that particular sample, which showed a negative MRD. One of the caveats here is the number of events analyzed in those days was 2017, was 10 lakh or 1 million, but the MRD was next. So even at the molecular level or at the submicroscopic level, there was no evidence of disease on the aspirate sample. But in the biopsy tells you a different story. So what you can see here is that in one area of the marrow, there's a hypercellular section with increase in immature precursors, which are highlighted by the TDT immunostaining, and the CD34 staining was cells not express CD34, but they express a lymphoid precursor marker. And another area where the marrow is actually normal cellular. So this suggests that because of its multifocal nature, one has to have a high index of suspicion and need to be a bit circumspect about calling somebody isolated without doing the appropriate diagnostics. And that requires, in our case, in patients in whom there are no circulating blasts with extramedullary marrow, one may need to, even in the same skin puncture, collect biopsy samples from two different passes. Increases the probability of trying to diagnose the disease. We often do bilateral marrows, but these are not evidence-based, but I'm just putting this out for your consideration. Now, this is a slide from a patient with lymphoma, but just to tell you that this is how it appears. Unfortunately, I don't have the marrow section of this patient, but this kind of patchy multifocal, this is, as you can see, a clump of malignant cells. This is CLL lymphoid, CLL leukemia cells in the background of normal marrow. So this is a paratrabecular interstitial pattern, but the marrow, so it depends on where you sample the marrow from for the aspirate, and the biopsy then gives you a clearer picture. And this is also highlighted in this particular case report, which in this particular case, the lymphoblasts were avidly took up 18 FDG PET. And you can see that there is multifocal skeletal disease. If you can see my cursor, nodal disease and long bone disease, but disease absent in the flat bones, and especially around the pelvis and the sacrum, which is the sites of marrow sampling, the posterior superior iliac spines. But in rest of, so therefore it depends on where you sample. This awareness must be there when you try to identify the site of disease. Not easy, but just to keep in mind. The second presentation, which I want to highlight to you, is the way in which it presents as part of the CNS disease. It can present as a deposit of leukemia within the anterior segment of the eye as a pseudohypopyon. And one then needs to do an iris paracentesis and collect the sample, do it through flow and establish that this is indeed leukemic blast. So these are the two other presentations I want to talk about. CNS I will skip, testes I will skip, and also sometimes these cutaneous deposits which require biopsy and confirmation. So this is the other unusual nature of ALL in the relapse setting, but it tends to behave as an extramedullary disease. So I shall skip alleviate, communicate, and support and move to stratify, review, and plan. And this was highlighted by Dr. Dharani very clearly, but for a jobbing clinician to try and keep these things in mind, let's start from the top. So we ask these kind of questions. So if you are in the Advaitic philosophy, you have yes, yeah, no, 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 neti kind of philosophy. So here too, we ask these questions. Does the patient have high-risk genetics? Is there T-cell lineage? Is it early relapse? An early relapse from a clinical perspective of whether it's happening on treatment or very shortly after completing treatment. In the absence of all these, then if these are absent, then we look at treatment response. And if the treatment response also is satisfactory, then we characterize as clinical standard risk. On the other hand, if any of these factors are present, then this patient will be, for purposes of management, clinical high risk. And what distinguishes that is the definitive treatment. The definitive treatment in clinical high risk is allogeneic hematopoietic stem cell transplantation, whereas for clinical standard risk is chemotherapy alone, plus or minus radiation therapy for sites of extramedullary disease. There are some caveats here. I want to make 2 points, and this is based on Dr. I hope I've got her name right, Dr. Hansika's presentation. And it is the cytogenetic panel that was used, was presented. It looked to me like an RT-PCR panel for 4 translocations, ETV6-RUNX1, TCF3-PBX1, BCR-ABL1, and MLL-AF4. Now, if you just do that approach, you will limit the information that you can gather from characterizing genetics, because you miss the aneuploidies, which is hypodiploidy and high hyperdiploidy. One also then misses MLL rearrangement with other partner genes. So this is another point to remember, that having a 4-panel RT-PCR for genetic is probably restricting and not sufficiently informative. So one has to have genetics in the mix. So the second case report of a patient with isolated testicular relapse, the genetic information was not there about what is the underlying genetic, and one cannot say that this is cytogenetically normal or cytogenetic non-high risk in the absence of other complete information. So just a point to remember in current practice. So now there are 2 protocols that were introduced. One is the ALL-RES BFM protocol. The BFM group is a group from Germany, Austria, Czech Republic, and Switzerland. The protocol that is in place is between 2002 to 2015. And there's the ALL-R3 protocol, 2003-2013 was when the clinical trial concluded, which is a UK-based protocol. Started in the UK, but involved Ireland, Netherlands, Australia, and New Zealand. Now, these 2 protocols are different in their philosophy, but the outcomes more or less are same. Of course, as a biased user of this protocol, I would instinctively favor the ALL-R3 protocol, but I just want to let you know that objectively, hang on. Hello, are you able to see my screen? Yes? Sorry, yeah. So,
yes.
Yeah, okay, thank you. So the ALL-RES protocol is based on blocks of treatment similar to, remember I told you that because it's a multifocal disease, treatment is given as punctuated blocks with intervening rest phases, similar to how we treat a solid tumor, because in the relapse situation, leukemia almost behaves like a solid tumor, and that is how the philosophy of the BFM was and how the protocol has been designed, whereas the ALL-R3 protocol is more in lines with continuous assault on the leukemia cells using multi-agent modalities. So if you look in the ALL-R1, there is an induction phase. So in the induction phase, there are the foundation blocks in the BFM group, which use high-dose methotrexate, quite toxic, whereas the ALL-R3 as a standard induction with the agents which we recognize, and the most important the agent which makes a difference is mitoxantrone. Then in the BFM, they have moved away from this punctuated blocks of R blocks and given a protocol 2 IDA. So protocol 2, if you people familiar with the BFM protocol, it refers to the delayed intensification protocol. But idarubicin is the anthracycline here, which is given for 4 doses. Consolidation in the ALL-R3 uses these drugs. R blocks are the punctuated blocks in the BFM protocol, which I talked about. R1 having high dose RSC, R2, so R1, R2, R2, R1, R2, those kind of iterative blocks, whereas, and R2 has daunorubicin and ifosfamide. Ifosfamide replaces cyclophosphamide because it's less gonadotoxic. Intensification in ALR3 includes high-dose cytarabine, a very toxic phase of treatment, not at all. And then there are the maintenance phases. And these red blocks tell you where patients come off for transplant. In the BFM blocks, patients come off a bit early or sometimes later, whereas in ALR3, patients come off after induction. So this is just to introduce you to the protocol, not the details, but just it depends, whichever center uses, just be familiar with the protocol you use. Not much to choose, and depends on what bias you have and working with. So the first point to make is how does cytogenetics determine outcomes? So this is the data from the UK LLR3 group published in Blood some years ago, showing that genetics influences outcome. And you can see this. So when I refer to cytogenetics, I'm talking of microscopy-based genetics and karyotyping, fluorescent in situ hybridization for identifying gene fusions, and aneuploidies are identified by karyotyping, sometimes supplemented by flow cytometry-based DNA ploidy. And if you stratify these patients, you can look at the event progression-free survival on the y-axis and follow-up time on the x-axis. You can see that there is a difference between, depending on whether you're high, intermediate, or standard risk cytogenetics. And on top of that, molecular genetics are increasingly playing a part in risk stratification. And these are some of the points, genetics that are coming into more newer protocols, include both cytogenetics and molecular genetics, especially TP53 alterations, which are very rare in the front line, are very enriched in relapse and portend a poor outcome. The next important thing is MRD. MRD, minimal residual disease, and sensitive measurement of minimal residual disease using accredited assays are important determinant of outcome, both in high risk and standard risk relapses. Remember, clinical standard risk relapses, remember I said that are those that happen late. And here, but if late bone marrow relapse, the practice was to stratify patients based on end of induction MRD. So receive the ALLR3 induction, and based on MRD at a threshold of 1 × 10⁻⁴, patients were administered either chemotherapy or RT. And what you can see here is that patients who had just chemotherapy alone, the 72%, the group of patients, 82, who had chemotherapy plus or minus RT for sites of extramedullary disease had excellent outcomes. 70% with that as a confidence interval of progression-free survival, which is in relapse settings is equivalent to event-free survival, in my opinion. And then the high-risk relapses the patients with late relapses but high MRD do less well. They were administered transplantation, this group, the red group. Yeah? So here it tells you that in late bone marrow relapses, be they combined or isolated, MRD is an important determinant of outcome. And also patients with high end of induction MRD, the end of other patients who require additional therapy with bone marrow transplantation or blood stem cell transplantation. And just move. That's also true for standard risk relapses. So just now in the previous slide, you saw that the outcomes for late bone marrow relapses, good MRD outcomes, 72%. Patients with late bone marrow relapses, high MRD with transplants, about 50+%. These are patients with high risk relapses, the clinical high risk that I referred to earlier. And I want to take you through 2 points. One is, if you start with these patients, this is combined BFM ALLR3 data. And what you can see is that nearly a third of patients do not achieve remission here, be they B or T. And only half of patients arrive at the time point of transplant because many events happen in the interval. Death due to treatment-related toxicity or relapses early during treatment. And of those patients, only half actually do well and hold their remission. So that means the ultimate outcome is about a quarter of patients. So starting from here, a lot of attrition, and only a quarter of patients hold their remission. And here too, so that shows that there's a difficult disease to cure with this conventional approach. And here too, MRD is an important determinant. So patients who have good MRD responses, end of induction MRD, which is either less than 1 × 10⁻⁴ or between 1 × 10⁻³ or 1 × 10⁻⁴, these patients do better than patients who have high MRD at the end of induction. And the other point is that prior to transplant, the important endpoint is to achieve an MRD less than 10⁻�3. And patients who have MRD higher than that have very poor outcomes. So 10 power minus 3 is an important determinant. I'm going to skip this slide. It is there in the paper, and I don't want to talk too much about this because this is not essential for the purposes of this talk. And the way to transplant patients, therefore, is to give TBI-based conditioning. And this is another for people who are in training or preparing for exams. The forum study, this is the for omission of radiation in underage minority or majority people, is the showing that in the intent to treat as well as treated analyses, patients who receive TBI-based treatment did better than those who received chemo-based conditioning for transplantation. And one of the important drugs which has made an important impact in managing patients, especially with high-risk disease, is blinatumomab. So for people who are not aware, blinatumomab actually is actually a contraction or a compression of the word B lineage anti-tumor monoclonal antibody. Yeah, so it is for B lineage disease, a CD19 targeting T-cell engaging antibody, a synthetic antibody. So in this design, which is from the COAG-ALL1331, it's a landmark trial. And in this age group, patients were either randomized to chemo-based post-induction treatment or blinatumomab-based treatment. Blinatumomab treatment was given as 15 microgram per square meter per dose and daily for 28 days, 2 cycles. And what you can see here is that all the endpoints in terms of survival, even though the study had to be terminated early because early survival signals were so strong, so the DSMC halted the study. And what you can notice is that treatment-related toxicity is lower, outcomes are better, and importantly, response measures, which are also surrogates of outcome, are superior to that of chemotherapy-based conditioning. If you read the paper, it's a very well-written paper. You will also see that the non-fatal adverse events were far fewer in the blinatumomab group compared to the compared to chemotherapy alone. So this is an important agent, though it is out of reach for our patients. So having taken all this information, how do we then manage and monitor? So as a clinician facing a patient with relapsed ALL, what do we do? So it's important here to have certain points in one's mind when making decisions about how to manage the patient. And the question is, are we the best center to treat this patient? Are we able to do the right diagnostics and monitor minimal residual disease? Do we have the experience of taking these patients through treatment? And do we have the specialized interventions that some of these patients may need, or do we have the ability to refer these patients for these specialized interventions? Yeah, and immune therapy here refers not just to antibody, but also cellular therapy. And as you know, there's an active CAR-T program in several centers, including at Tata Mumbai Hospital. I put the link here for Dr. Narula's talk in VJ Hemonc, which is a video journal of Hemonc. And there are publications from Christian Medical College Vellore as well on their work. The next thing is when you make a treatment plan, one also needs to know what prior treatment patients have taken, because that influences decisions regarding cumulative drug dose, prior exposure of, for instance, radiotherapy. Some patients may have asparaginase hypersensitivity in the frontline trial, and therefore that drug has to be omitted perhaps or rechallenged. And some patients who have infection history may have recrudescence of infection during the relapse management. A supportive care plan has to be drafted, and you're familiar with this, but often we forget about symptom mitigation palliation and a lot of engagement with families. And this treatment intensive families also change as families become more, as they have time to internalize and understand what is the decision that they want. And sometimes families also request opinions in other centers, and it is our responsibility to facilitate as well. Now, I've said monitor, and monitor does not just mean MRD, but also monitor patients using this is how we, for relapsed ALL, we have these weekly clinical review meetings. So this is a patient, in the case in point, Dr. P.S. Roy attends some of our talks as well, some of our meetings. So this is from October 22. So we so you can see all summary information of the patient on the left-hand side, and then the frontline information, the current, all the treatment has been given in relapsed ALL management, and what is the current status here, and what is our plan for these patients. So this kind of monitoring is required for these patients because it's a very dynamic process, and that is important. As I've highlighted doxorubicin because there was a crisis, national crisis in accessing mitoxantrone, so we had to use doxorubicin, which is an unsatisfactory trade-off. Now, I want to, this slide, this is actually clinical study data, so I'm not at liberty of sharing this, so please do not take pictures or record it. But I want to highlight to you that, that the Indian Pediatric Oncology Group Protocol for Relapsed ALL, regrettably, it is still a single center study because the study database has only now been developed for a multi-center clinical trial. It took a long time to do so. But what you can see is that this is an ALL R3-based protocol for people who are interested. It uses bortezomib instead of incristin induction and uses a modified intensification schedule to decrease toxicity. This data that we are presenting is from this period. And so many patients, so see, only about 50% of patients actually could go through this treatment. Majority of them did not opt to go through because of psychosocial reasons or because of disease, the type of disease, which is probably difficult to cure. So what you can see here is that if you're clinical high risk, the probability of having toxic events is higher, so 3 and 4% versus those who are in standard risk. And then the possibility of experiencing, so 27%, either non-remission or death compared to those who had standard risk disease. So just to let you know, this is a recurring problem. That's high-risk patients respond poorly and have early treatment failures. And because of the augmented toxicity of the drug also, and probably because the bone marrow is not healthy to tolerate intensive chemotherapy, also experience high infection-related mortality. This is a big problem. This is the last 3 slides, and it's very important. This is a personal lesson, and I'm sharing what I've learned from patients. It's important to alleviate, communicate, and support. As a physician, often one has a nihilistic attitude towards relapsed, and there is a feeling of sometimes it's, even though one may not say it in one's language, one sometimes communicates it through one's body language and one's sense of defeatism. And families often do not, even though families realize it's a catastrophic news for families, families often wish the physicians to present all options objectively and then work with them to achieve what the families wish to go. Sometimes we may have to guide them in the decisions, but it is, I've learned that it's important to be part of this journey. One point to highlight is that in the absence of any treatment, any disease-directed management, just using painkillers and pain management and transfusion, often the treatment, this is from data from China, the clinical course is rapid, so rapidly fatal. Even though here, if you look, the curve hits 5%, and the 5% because patients were lost to follow up. It's about within 12 months. I think majority of the patients actually see within about 3 to 6 months. Yeah? Maybe 6 months is probably sometimes earlier than that. So, and these patients often have a difficult death, a lot of disease-related symptoms. So disease-directed management, even though it may not be curative, is still the best palliation. That is what we have come to learn. We knew this, but we have, so that's the point being made here. So curative management and non-curative, this is again IMPOC data. And I want to show you that there is a third, so just now move to your eyes to the right side of the screen. The point I'm here is early follow-up, but the patients who are clinical standard risk and the non-high risk patients, these patients have actually very good outcome, even though the data says 92%, and you can clearly see it's not 92, but because the follow-up has not matured, therefore the 2-year follow-up seems very impressive. But even at 2 years, at 3 years, when you come to the 40-month mark, it's 75%, and these numbers we are seeing this as a conserve. So it's about 75%. Maybe even if one's about 60% of patients with clinical standard risk have good experience a second sustained remission. And that's about a third of the patients. High-risk patients, similar to what international groups have reported, do poorly. And better solutions, especially if they don't receive transplant, which is another challenge in our community. So I want to end this by 2 points. So I said 3 initially, so I'm correcting myself. So the first is, even in the absence of non-curative management, disease-directed management is important. Sometimes you have to act in a very speedy fashion for patients who have central nervous system disease with raised ICP or altered consciousness, or patients who have nerve palsy, especially eye palsies, who have impaired vision, and patients of skeletal pain where you need to intervene with steroid incristin to try and alleviate the pain. So then the diagnostic workup has to be accelerated to enable these treatments to be delivered. Then life-extending treatment is also worthwhile, and one has to balance quality of life versus the cost of treatment. These are some of the options which we normally consider. Low-intensity chemotherapies with intrathecal, steroid vincristine, antimetabolites, and asparaginase, plus or minus, or moderate intensity therapy, which consists of parenteral drugs. And sometimes radiation therapy is good for focal disease, especially if it's, for instance, testicular disease, in addition to systemic disease. And patient supporting the family is a very important part of the journey. And I will talk, and I'll conclude with the last slide. And it's not so much the consent process, but it is to understand the patient's family's expectation. I've paraphrased it from this particular commentary in the journal Bone Marrow Transplant. It's understand patient's family's expectations and fears, and the team and patient to clarify ongoing and onerous nature of cancer treatment and the need for therapeutic adherence. So it's actually a dialogue. And the families wish to be reassured that the clinical team is expert, experienced, attentive, and that they have prioritized the family's interests and are available for the family to lean on as they go through this journey. So I think that is what I have learned personally from this particular looking after patients. With that, I think I'll end the talk, and there are many people whom I wish to thank. Chief among them is my mentor, sometimes tormentor, Professor Saha, and Dr. Cornelia Eckert, who is a remarkable person. She's from Germany, from this hospital called the Charité University Medical Center, who has helped us set up the molecular MRD using PCR-based MRD, which has helped us manage patients on the relapse protocol, and which we are hoping would be something that can be made available more widely for patients across the country. With that, I end my talk. Thank you very much for the opportunity.
Thank you so much, sir, for that again topic. And I think reiterated quite a bit on the holistic management and the management not only the hefty chemotherapy and biologicals, but to compassion and give holistic care. So, any question? I can't see any question posted in the chat box. So anytime, I think the audience can get questions. Can I have one question? So the UCAL R3 restratification, it stratifies the early isolated relapses as intermediate risk. It says that intermediate risk, the therapy is chemotherapy versus HC has to be. So there is something persisting. So extramedullary disease, it is no question of assessing and induction MR. How does one take a call whether to go for HC or cognitive chemo? That's question number one. And another question is, I know your center does quite a bit of amazing activity on this, Dr. Sheikh. Where do you see the role of drug profiling, drug response profiling in next of relapsed refractory disease in the near future, in LMICs?
So shall I take both questions or?
Both questions.
Yeah, thanks, Amita. So yeah, so in patients where there is absence of disease in the marrow, and therefore one has to rely on extramedullary sites to assess remission, we use a traditional approach that we use in frontline ALL. Patients receive, for instance, the central nervous system disease, CSF disease. Yeah, so remember, patients who can have meningeal disease and parenchymal disease as well. So I fully accept your point that in meningeal disease, CSF will guide us through, and this will mainly through cytospin assessment, looking for blasts, and CSF hemocytometer count. We do not do CSF flow cytometry because we do not know how to use the information in management. For non-meningeal CNS disease and for disease in other sites such as the testes, we use a combination of clinical and where feasible imaging analysis. We do not, so for instance, in testis disease, we will look for testicular response at the end of, by the end of intensification phase, testes, which is both size and consistency, that of its appropriate for that patient's age. And for other sites of disease, we will do imaging. So we will, if there is a disease site which has been picked up through imaging, if it's a scalp nodule, for instance, we will just use clinical follow-up to make a decision. So these are some of the limitations. In future, just to add to this point, if our technologies become so sophisticated that we're able to pick up circulating disease in the peripheral blood, then that will be something to add on to this. But at the moment, we do not have the technologies to be able to sensitively monitor sites of disease outside the marrow. This is a limitation of management. Second point is drug response profile. Sorry, Dr.
Sorry.
Preetham.
So you take no, sir. So in this limit existing, would you take an early isolated CNS relapse for ages, or isolated testicular relapse for ages? For
Dr. Preetham, unfortunately, because where I'm seated, I'm unable to hear your question very clearly. But I think what you said is that how do we then manage? Sorry, I sort of lost the question. You said early isolated CNS relapse and early isolated testicular relapse.
Yeah.
Preetham, your voice is breaking. We didn't get your question.
Yeah, I struggled to hear as well.
Yeah.
I'm in the chat box.
Yeah, just put it in the chat box. Your voice is breaking.
Right.
So what I will do is meanwhile, I'll answer Dr. Preetham's second question, which is drug response profiling. I would like to bring down the temperature a bit on this drug response profiling, even though it was presented at by colleagues from our unit it is perhaps one way where we think we can reposition or repurpose drugs in our context, where access to expensive but impactful therapies are not readily available. It is probably for the future. But I think our attention should be what we can do now. What we can do now, I think, are three things, in my opinion. And Dr. Amita, I would request her to also correct and contribute. So number one, I think, is that we have to standardize. So even in relapsed ALL, we have to standardize the genetic stratification so that we are able to identify whether they have a high-risk genetic profile or not, because that impacts the way we manage them. The second is that the MRD monitoring has to be, whether it be by flow or non-flow techniques, it has to be at an accredited center where we are able to sensitively establish, number two. Number three, I think it's important to be able to have because relapsed ALL is a therapeutically challenging disease. I feel that it is not easy. It requires a team which has experience in delivering this care. This is my opinion. I'm happy to be corrected, but therefore I feel that if I'm a physician sitting in a center where I'm not familiar with relapsed ALL management, after doing some initial diagnosis, I would try to refer this child to a center which has experience and understanding in managing and support the family in that decision. This is my thought, but I would like Dr. Amita to speak on this matter. Dr. Amita, please share your advice.
Yeah, Shekhar, I agree with you that in relapsed ALL, I think a lot remains to be seen and known, and especially understanding the biology, which possibly we're a bit behind. And that's what you were saying, correct?
That's correct. That's correct.
Yeah.
Yes.
So because upfront, yes, to do all the cytogenetic workup and all we are doing. And I think we have to face the fact that to do more cytogenetic workup than what we're doing already at this point of time is financially a little difficult. And, recently there was this big talk about using NGS and all upfront, which again is at the moment until it's standardized, etc. I mean, especially for the younger crowd. I'd like you to understand, this is what I feel, that it's very easy to say, use, because NGS is available, use it. But the most important thing is that unless it's standardized and we know how to interpret it, we shouldn't jump into doing tests, which is what happens very often. And I totally agree. And I really, this is another really important point, that please remember that relapsed ALL patients are very fragile. They're like much more fragile than the first time around, and they crash much faster, which is why they really should be kind of in super experienced hands. We've had this experience despite being at a tertiary care center, that and then in retrospective we feel that possibly we could have done better in handling them. But it's a fact that what Dr. Shekhar said, that an experienced person should be handling the relapse protocols, because the protocols are pretty intense. So over to Dr. Shekhar or anyone else who would like to add on.
Thanks, Dr. Amita. I think what I will do is that, thanks, I have nothing more to add. I echo those points. So I have nothing more to, Dr. Amita has captured the main point. So I will just take one or two questions, and then I will ask maybe Dr. Dharani may want to step in as well at this point. So one question that I can see in the chat box is coming from Dr. Preetham himself. How would you consolidate an early isolated testicular CNS relapse with HSCT or chemotherapy? So this is a good question, and we do something atypical, and I would like to let you know this because so for early isolated CNS relapse, the experience with UKALL ALL3 protocol is that these patients are transplant requiring. It's a transplant requiring relapse. This is our understanding. It's a difficult relapse to treat and cure. Isolated central nervous system relapse, be it of T or B. Isolated testicular relapse in a young child with no high-risk genetics. Young child means less than 15 years with no high-risk genetics. Our practice, now this is again, I'm talking of institutional practice, so please take this with a great side order of salt, is to offer chemotherapy and isolated B lineage, testicular relapse, no high-risk genetics, age less than 15 years. Our practice is to give chemotherapy alone, consolidated with testicular radiation. This is our practice at the moment. The reason why I say there's no data is because for reasons, testicular relapse is a vanishing problem, it's a very rare problem in the West. So therefore, there's in the testicular, in the ALLR3 group, you will not see much data on what testicular relapses have done. So this is something that we see, especially in Kolkata. We have a large number of testicular relapse for reasons unknown. So this is our practice, and we have so far we've not regretted that decision, but the data has to mature before we can say this is the way to go. That's the answer to that question, Dr. Preetham. There's a question from Dr. Dharani asking about late combined testis plus BM. Do we offer HSCT? So again, in late combined relapse, because it's a marrow relapse, we would use MRD to determine marrow response, and we will use clinical examination to determine testis response. And if both are good, meaning end of induction MRD less than 10⁻⁴, using a suitably accredited MRD, and testis shows remission by the no disease at the end of intensification, then these patients will continue with chemotherapy and radiation therapy. That has been our practice. Please stop me in between if I'm just making mistakes. So pH-like ALL from Dr. Deepak Bansal is often not tested. Yes, correct. So this is one of the reasons why we repeat genetic testing, because some of the genetic testing that is offered in this may not have been available for the patient at the time of initial diagnosis. So correct. So our understanding now of pH-like ALL is that it is a poor risk genetic subtype, especially the pH-like Abel class ALL. And for these patients, we consider this as high-risk genetics and treat them as such with the chemotherapy followed by allogeneic stem cell transplantation. That has been our practice. We don't have any data to support. We are extrapolating experience from the frontline poor response for these patients. There is a question from Dr. Ruchi asking about large B lymphoblastic lymphoma, CT chest. Correct. So again, this is the problem that I mentioned earlier, that in the absence of molecular markers of disease, we use imaging criteria, and we use, so whichever imaging criteria we had used at diagnosis for a mediastinal mass, we will repeat that at end of induction. And at least by end of intensification, we should see no evidence of disease based on imaging criteria, and we use that alone to make decisions. Having said that, T cell disease, be it lymphoma, lymphomatous presentation, or leukemia presentation, is generally considered to be a high risk relapse, except in the very rare situation where it presents as late isolated extramedullary relapse situation. That in that situation alone, and I'm talking extramedullary, I'm talking of non-nodal relapse, meaning CNS or testes, yeah, which are very rare presentations. Dr. Manas has asked a question about TCF3 rearranged BLL. Correct. So this is TCF3 rearranged BLL has been in the ALLR3 protocol. TCF3 rearranged ALL has been found, TCF3 PBX ALL at front line in patients who relapse has had poor outcomes and generally moves along course or segregates with clinical high risk. For these patients, therefore, we would treat them as clinical high risk patients. So our current practice, so the question is for relapse patients, with those who are late relapse, does it mandate? Our practice now is all TCF3 relapses or IM21 relapses. We normally, even if it's late, we will recommend transplant as the definitive treatment for these patients. So those are our, so those are the questions from my, responses from my side. Dr. Amita?
No, I think we're absolutely fine. Dharni, would you like to add anything? And then we can kind of start winding up. Our time is, I'm sure it's everybody's dinner time.
Already detailed everything. I had a point about the NGS, at least in the relapse setting, those who are affordable, at least, like you said, unless we have standardization and how we know how to interpret, it's better not to do. But my question is it better to do in at least some people who are affordable and who, where they are thinking about transplant? So is there any?
But my question would be that rather than that, first, would it not be better to do the full detailed FISH workup for all the other translocations? Shekhar, what would you feel? And look for all the other, various translocations which we're not doing in routine. Because I am seriously have my concerns about NGS at this point of time in our country. So Shekhar, would you like to?
I'm 100% aligned with you on this point. I also feel that as physicians, we should focus on things which are going to influence our clinical decision making, and cytogenetics is well characterized and well understood. There's a lot of experience. NGS technology at the moment, whether it is serving mainstream plans, so I'm hesitant to bring it into at the moment. So same point, and I'm just saying the same thing. Yes, 100% alignment with what ma'am said, that yes, we will, instead I would focus on strengthening our cytogenetic analysis, bringing in aneuploidy detection using either flow-based DNA ploidy analysis or using karyotyping. Karyotyping is a bit more difficult, so flow-based DNA analysis can allow you to identify hypodiploidy, which is an important risk group, which is not picked up with the 4-panel RT-PCR, and expanding the FISH probe to include IM21, now doing a FISH-based rather than detecting translocations using a FISH-based approach rather than using RT-PCR is something else we would advise. And I think the combination of those will allow you to at least pick up 80% to 85% of the prognostically important genetic markers. That's
Thank you, sir. So there's a final question from Dr. Silki. She has asked, can we define combined relapse on the basis of bone marrow MRD more than 1%?
May I take a stab at it?
Sure, sir.
Yeah, so current classification talks of microscopy-based, so as Dr. Dharani pointed out, combined relapse is a bone marrow blast more than 5%, and bone marrow relapse more than 25%. This is the way you may disagree with it from a biological point of view, but in terms of how we report in a standard way and manage, this is the way we are currently managing. So unless there is evidence to ask us to do otherwise, I would hesitate to, I would use standard definitions for risk stratification. You may later say that, yes, in this patient, there was an MRD more than 1%, even though and therefore this patient should have been, those are data that may come later, but at the point in time, microscopy-based classification is the way in which we practice risk stratification in relapsed ALL for the current era. And that is what I would recommend that we stick with as standard practice first. Dr. Amita, your thoughts on this point?
I agree that I think until we have some definite guidelines, I'm kind of very, let's say, traditional in a British style manner that we continue as per the definitions and not change on our own.
Okay, so I think with this we reach the very end of this session. We thank all the three speakers for sparing time on this evening to educate us on this topic. I will just take 1 more minute to announce the next session. We thought we will take a small, summer break for a month in April. Our next session will be in May. The date is 11th of May at 7 p.m. as usual. And the topic we have chosen for that session is the inherited bone marrow failure syndrome. The case presentation will be from Postgraduate Institute of Child Health, Noida, under the guidance of Dr. Neeta Radhakrishnan. And that will be followed by discussion on molecular workup in IBMFS, what a clinician should know. Dr. Pratik Bhatia from PGI Chandigarh will give a lecture on this. With this, we thank you all for your time and active participation. Good night.
Thank you.
Thank you, Pritam, Vandana, Shane. Thanks a lot.